My name is Dr. Cynthia Delgado. I'm together here with Dr. Flor Alvarado. We are delighted to be invited to the Renal Reason Institute to present on the systemic and cultural barriers to patient care. These are our disclosures. The objectives for today's talk is to briefly go over the national data on the incidence of end-stage kidney disease and the disparities in care. Then we'll dovetail into the discussion on cultural and systemic barriers to patient care. And then finally, we'll explore next steps in bridging the gaps. First, we're going to start off with the review of the USRDS data, and I'd like to hand it off to Dr. Alvarado at this time.
All right. And so when looking at the adjusted incidence of end-stage kidney disease, or ESKD, between the years 1990 and 2018, we can appreciate that it has remained relatively stable over the last few years. And now, looking at the adjusted incidence of ESKD stratified by race and Hispanic ethnicity during the same time frame, on the left, we can appreciate that while the incidence of ESKD in Black individuals has been on the decline in recent years, there still exists a significant disparity, as is the case with American Indians or Alaskan Natives. Similarly, on the right, one can also appreciate a persistent difference between Hispanic versus non-Hispanic individuals. And so why might this be occurring? Well, while presumably multifactorial in nature, one key issue that's worth highlighting is the continued disparities in those receiving pre-ESKD care. And so let's look at this. So in this figure, pre-ESKD care is stratified by race, specifically white, Black, American Indian or Alaskan Native, Asian, Native Hawaiian, or Pacific Islander. And the different durations of pre-ESKD care are color-coded on the right-hand side. What we can see is that Black individuals and Native Hawaiian or Pacific Islanders, as highlighted in green, are less likely to receive any pre-ESKD care as compared to whites and Asians. And the implications of these differences are significant. Research has shown that patients with incident ESKD who do not receive preceding nephrology care are unlikely to receive dietary counseling. So longstanding history of high phosphorus intake, for example, may lead to irreversible cardiovascular effects. They're also less likely to receive an ESA, and they're have more than 80% probability of initiating hemodialysis with a catheter. And as you may suspect, these findings are not new, but what you may be surprised to know is that the data hasn't changed much over the years. And in fact, in their national registry study of adults initiated on maintenance dialysis in the US from 2000 to 2015, Renal and colleagues found that racial and ethnic disparities in pre-dialysis nephrology care did not substantially improve during this time period, even after adjustment for clinical and demographic factors. And so, keeping these observed disparities in mind, the question one might then ask is, well, what are the underlying cultural or systemic underpinnings perpetuating these issues and impeding delivery of equitable patient care? And this is what we'll move on to next. So it's crucial to recognize patients' cultural and personal preferences. And a few of these include language, dietary habits, including awareness of ethnic-specific food contents, religious restrictions, as well as religious practices such as prayer schedules, and other specific provider preferences. But what's key to these cultural and personal preferences is the communication between patient and provider. So let's delve into that a little bit more. First, we'll touch briefly on racial discordant patient-provider interactions. So racial discordance refers to having a shared identity between a physician and a patient regarding their race, whereas racial discordance refers to patients and physicians having different racial identities. In one of the earlier studies looking at this in 2003, Drs. Cooper and colleagues found that race concordant visits were more likely to be longer, earned mean ratings of positive patient affect, and patients were more likely to rate their physician as participatory. Similar findings have been appreciated in subsequent studies over the years. Indeed, in their review of the literature in 2018, Johnson, Shen, and colleagues found that Black patients tend to experience a lower quality of patient-physician communication as compared to white individuals. And so continuing with the theme of communication, we discussed a timely piece published July 2020 by Drs. Cooper and Cruz, in which they describe two key and practical components of communication that can be applied to everyday patient encounters. One, relationship-centered care, and two, structural competence. In relationship-centered care, all participants appreciate the interconnectedness with one another. Patient-provider relationships are critical to relationship-centered care, but there are other connections that are worth considering, such as the relationship of the providers with themselves, i.e. self-awareness, that with other colleagues, and their community at large. Moreover, since disparities in healthcare and research have their roots in structures and policies that are broader than interpersonal relationships, structural competence has been proposed as another approach to addressing the many factors leading to poor health in vulnerable and underserved communities. And addressing structural competence requires, as listed on the figure on the left, awareness of inequities, transparency, increased funding for health disparities work, as well as diverse participation and leadership. Together, these approaches can help fortify trustworthiness in healthcare delivery and research. And now, switching gears, we'll focus our attention to an important systemic barrier, homelessness. And so while you may come across various descriptions in the literature, one can define it as when an individual is living in locations not meant for habitation, those residing in emergency and transitional shelters, or those staying with friends or family due to a lack of shelter. Research has found that homelessness is associated with higher mortality, longer and more costly hospital stays. And in the kidney arena, homeless patients with chronic kidney disease have been shown to have higher risk of ESKD progression and more likely to visit the emergency department, but are less likely to access pre-dialysis care. And unfortunately, there's limited data examining outcomes or prevalence of homelessness among patients with end-stage kidney disease, in large part because it's not mandatory to collect data on the housing status of our ESKD patients. And taking a closer look into the cohort study by Hall and colleagues, they examined a little over 1,500 adults with chronic kidney disease stages 3 to 5 that were receiving ambulatory care between 1996 and 2005 from the Community Health Network of San Francisco. They were interested in 1, time to ESKD or death, and 2, frequency of emergency department visits and hospitalizations. Over a median follow-up of 2.8 years, they found that homeless adults experienced significantly higher accrued risk of end-stage kidney disease or death as compared to housed adults, and this is highlighted on the left. This elevated risk was attenuated, but remained significant even after controlling for differences in sociodemographics, comorbid conditions, and laboratory values. Moreover, homeless adults were more likely to use acute care services. As highlighted on the right, the median number of emergency department visits was 9 for those with homeless status, compared to 1 visit in those that had housing. A significant difference was also appreciated in the number of hospitalizations between the two groups. And so a framework for this relationship between the broader issue of housing instability and end-stage kidney disease has been proposed by Drs. Cruz and Novick. People with housing instability face multiple barriers to optimal care, which in turn pose challenges in the setting of end-stage kidney disease, such as being able to get to their designated dialysis centers, storing and managing their medications appropriately, and following recommended diets. Moreover, homelessness likely precludes appropriate management of end-stage kidney disease, leading to fragmented medical care and subsequent health complications, thus perpetuating the cycle of housing instability and homelessness. Another key concern is that of food insecurity. And in today's climate, this is especially important. And so what is food insecurity? Food insecurity is the inability to afford nutritionally adequate and safe food. Studies have shown that it contributes to chronic disease, worsening mental status, and higher all-cause mortality. It has also been associated with increased prevalence of chronic kidney disease, even after adjustment for socioeconomic status and smoking. Furthermore, Banerjee and colleagues showed that food insecure adults with chronic kidney disease were more likely to progress to end-stage kidney disease after multivariable adjustment as well. Specifically in children with end-stage kidney disease, Starr and colleagues also found that food insecurity is associated with increased emergency department visits, hospital admissions, infection, and poor quality of life. And so to home in on the study by Dr. Banerjee et al., they were interested in assessing the impact of food insecurity on progression to end-stage kidney disease. They studied a little over 2,300 adults with CKD and over 10,000 adults without CKD from NHANES 3 with household income below 400% of the federal poverty level. And over a median follow-up of 12 years, they found that among those with CKD, food insecure adults were more likely to develop end-stage kidney disease as compared with food secure adults. And this here is underlined here on the right. And this was after adjustment for demographics, income, diabetes, hypertension, estimated glomerular filtration rate, and albuminuria. Interestingly, by adding nutritional factors, including total caloric intake, BMI, and daily acid load, the relative hazard was attenuated and was of borderline significance, suggesting that food insecurity might lead to end-stage kidney disease through direct effects of diet quality on kidney health. And so now we've walked you through a few of the many barriers to equitable patient care. What we want to do now is leave you with some practical solutions and general advice on how to help overcome some of these hurdles and incorporate them into your own everyday practice. So begin first by actively seeking out subtle patient stressors. While issues such as housing instability, food insecurity, and mental health support may be considered extra-renal, I hope that we've convinced you that these are risk factors that deserve our attention when providing equitable patient care. With that, let's explore 2 screening tools that you may be able to incorporate into your own practice. First on the left is the Accountable Health Community's Health-Related Social Needs Screening Tool. It was created by Center for Medicare and Medicaid Services, Center for Medicaid and Medicaid Innovation. It's a simple 10-item tool that inquires about 5 core domains: housing instability, food insecurity, transportation problems, utility help needs, and interpersonal safety. And on the right, we have the Hunger Vital Sign, developed by the Children's Health Watch team. It's a validated food insecurity tool that's used to identify households at risk of food insecurity, and it consists of 2 statements. Statement 1 reads, within the past 12 months, we worried whether our food would run out or before we got money to buy more. Statement 2 reads, within the past 12 months, the food we bought just didn't last, and we didn't have any money to get more. The instrument identifies households as being at risk for food insecurity if they answer often true or sometimes true to either of these 2 statements. And so we've previously mentioned the paucity of data looking at outcomes related to homelessness in individuals with end-stage kidney disease. And this is just one example of data collection that might help in furthering disparities research in the subgroup, amongst others. And this could be accomplished by adding questions about homelessness in existing CMS forms, such as CMS 2728 forms when individuals are initiated on dialysis, as well as the annually completed CMS 2744 forms. Additionally, collecting data on our team members would be helpful to evaluate if our workforce is reflective of the communities we serve. Again, we can't identify gaps in care unless we actively seek to uncover them. And of course, this would require the cooperation of multiple stakeholders to change data collection practices. And so in order to practically apply lessons from relationship-centered care and structural competence to achieve healthcare delivery that is equitable and worthy of trust, the best place to begin is where each of us are. As Cooper and Cruz describe, As individuals, we can commit to becoming more aware of our biases, and successful approaches to this, include training in self-awareness and professionalism. With our patients and our research participants, we can use relationship-centered behaviors such as probing with their perspectives with open-ended questions, asking for their input on decisions, listening respectfully, empathetically, and avoiding racially biased treatment or stereotyping behaviors. Relationship-centered care also means providing patients and research participants with information in short, clear statements with opportunities to ask questions and preparing them for what comes next, whether that be diagnostic tests, treatments, research protocols. And so we should also hold institutional leaders accountable for implementing policies to make workplaces diverse, inclusive, and collaborative. We should also advocate for greater funding for healthcare, research, and services that benefit the socially disadvantaged. And after a year like 2020, these lessons are more relevant than ever. In their poignant perspective piece, Dr. Cruz and Purnell underscore the consequences experienced by Black patients as a result of the combined health disparities related to COVID-19 and the high-profile acts of racism. They further provide recommendations for the kidney community's response in mitigating these disparities. And we've incorporated most of them in our presentation today. However, it's worth highlighting their emphasis on engaging with community leaders and organizations to build trust, and to supporting our colleagues, but also holding each other accountable moving forward. And in closing, what are a few things to take away from today as we continue to fervently care for our patients? Well, we can be curious, taking the time to learn new aspects of the day-to-day of our patients' lives, incorporating the use of screening tools, asking open-ended questions, and recognizing that non-adherence may in fact be a red flag for unmet needs that we should address. Furthermore, be clear and concise when providing advice, explanations, or instructions. Engage both with your multidisciplinary team and your local community organization and leaders to achieve comprehensive and relevant patient goals. Use data to advance policy and patient advocacy efforts. And of course, committing to continual self-awareness and assessment, while also consistently holding our team members accountable in an earnest and empathetic manner. With that, thank you. We would also like to thank a few individuals for their help and mentorship in this presentation, such as Dr. Cruz, Johansson, Dr. Poe, Purnell, and Dr. Novick, and everyone from the ASM Diversity and Inclusion Committee, as well as our respective institutions, the Division of Nephrology at Johns Hopkins Medicine, the Welch Center at Johns Hopkins as well, San Francisco Veterans Affairs Healthcare System, and UCSF, University of California, San Francisco. Thank you, and with that, we'll take questions.